So Mariama's now been moved from the isolation cubicle on the main corridor of Ward 19, where her previous care over the weekend had been undertaken, and a critical care referral for formal reviews being made, and the ID team are now ready to hand over to critical care. Kath and Louise are our critical care team. We're just receiving a verbal handover now from Ewan and the ID nursing staff who have been caring for Mariama over the preceding hours. This phase we would really interpret as our usual HDU admission style activities, with just continuous monitoring being applied and addressing the priorities in a usual fashion for admitting any patient who had gone beyond a point where ward care was reaching their needs. Aseptic practice obviously somewhat challenging in this environment, very different from our normal processes, but best adaptation to try and maintain PPE cover while also maintaining sterility as well as we can for these procedures. So Louise is going to conduct an intubation checklist in the normal fashion that we would when anaesthetising a critically ill patient. The PPE practice for the central line we've chosen here is just a pair of sterile gloves for the operator, conventional sterile fields, and then just really good wire control. Try not to contaminate the wire as you're inserting the line.
Welcome to day 2 and phase 3 of the simulated exercise. We pick up where we left off pretty much last night. The patient remains under the care of ITU and ID. So any equipment that was brought into the room yesterday has remained in. We've still got the ultrasound in. CTG machine is on, patients on continuous CTG. And ITU have just finished off stabilising the patient and they're ready for handover to the theatre team. So this is the anaesthetic team coming in. That is Sam, the obstetric anaesthetist, and Steph, the anaesthetic assistants. That is the Belmont rapid infuser with some bags of blood hanging. Sonia, the midwife, has come in with the caesarean section kit, along with Sarah, scrub nurse, bringing the caesarean section tray. This is going to be a moderately slimmed down team today, but obviously with the additions of ITU and ID in the room, it might get quite busy in here. The rest of the surgical team are still in the control room, waiting for the say-so to come through. So the surgeons are coming through now. This is Alex and Emily, who are the consultant obstetricians.
Okay. Sure. Yeah, sure.
We've also been joined by the two neonatologists, Richard and Kate, who are coming through to be ready to receive the neonate on delivery.
So, Tom, can you confirm our patient, please? Yeah, we've got Mariana Sesday.
So Sonia has just brought the whiteboard closer to the table. So Sonia is acting as the count nurse and runner today. The team are trying to keep a clean and dirty zone so that the people directly involved in patient contact, which is the scrubbed team, the anaesthetists and Sonia,
Can you pull Alex's gown up a little bit?
will unavoidably be contaminated in the event of hemorrhage, and we're trying to keep an isolation zone between those and the neonates and ID team. So the obstetricians have started the procedure. That's knife to skin. So this is the manoeuvring of the fetal head into position for delivery with some fundal pressure at the top end. Look like a head. Baby's coming out. Now, remember, the baby is under general anaesthetic also, so we usually wouldn't expect much crying, even in a well infant delivered under general anaesthetic. Of course, this baby has to be treated as if contaminated or infectious themselves until results prove otherwise. It sounds as if there's already a bit of bleeding. Some fresh red loss there going into the suction. Clearly identified as some bleeding that we haven't noticed before. That looks like some platelets that Tom is putting up on the peripheral line, which would come in the second major hemorrhage pack. Sonia is trying to mop up the significant puddle of blood on the floor. Which is obviously risk of contaminating the rest of the room. Would probably worth mentioning, Alex asked me to mention that the team are using blunt needles and have elected to use staples for the skin to minimise the risk of needle stick. Now, Emily's just tripped over. This is not planned. She looks okay. We'll just treat this as...
I think you've already reached, so you need to go outside.
So this is potential breach. Joe's just checking she's okay, first of all. She is okay. Sonia's checking she's okay. Midwife. Fortunately, it is the end of the surgery, although there's still quite a lot of cleaning up and sorting out to do. Joel is reported through to the intercom, to the control room to tell them we've got a staff member feeling unwell. Chris has decided that the safest thing to do would be to check that Kirsty's safe to stand, get her doffed and exit the room while we're waiting for replacement to come through from the control room and PPE. The surgical team are busy trying to clean up the remnants of the blood. Identified there's a lot of blood underneath the patient that hasn't been weighed yet or incorporated into the measured blood loss. That would usually be bagged and measured towards the end.
On the slide, nice and gently, guys. So I've got 2 handfuls of lines here. Ready?
The table's being pulled out, of course, that'll have to stay in the room until the end of the patient care episode. So the surgical team are going to start decanting over towards Chris for doffing of the top layer.
Can I just have a new pair of gloves? Right, Sarah, before you finish the scrubbing, can we just do the sign out, please, everybody? Okay, so the name of the procedure is being recorded as?
Cesarean section hysterectomy.
So the baby has been placed in the cot by the midwife. We can see that Katie, the advanced neonatal nurse practitioner, is moving the baby over to the resuscitation platform. She's just cleaned the baby with Octenosan mitts, and the baby is being placed inside a large sterile plastic bag. They're confirming that they've both seen the baby's chest rise, but the baby is not breathing for themselves because they've been anaesthetised. Therefore, they continue to breathe for the baby with ventilation breaths via a mask. You will see later on that we have another team outside, so we have a clean team and a dirty team. And the personnel that are in those teams are all capable of doing quite advanced resuscitation of the newborn independently, which means that we could switch people in if we needed to. The heart rate, however, is good, so we're very happy with the heart rate over 100 in the first few minutes. So we can see there on the video laryngoscope screen, Richard's just proceeding with intubation. We can just see there the vocal cords and a tube passing through those vocal cords. One of the real challenges for any newborn, but particularly in this setting, is actually keeping the baby warm. So whilst the staff may be quite hot in their PPE, the baby actually, we really want to keep as warm as possible. So the baby is lying on a heated mattress. So the resuscitation platform has a built-in heated mattress. And then we have an additional transwarmer underneath the baby. And the plastic bag will also help keep the baby warm. So when the team are ready with the doors, Katie has disconnected the baby. She's going to carefully walk across the room, watching for any trip hazards. So they are now placing the baby on a second clean resuscitation platform, ensuring that they stay this side of the dirty zone. So what they have done is placed the baby inside a second plastic bag and removed the dirty hat. The second team, you will see come in through the doors on the left-hand side of the screen. So Barra is the senior doctor and Jane is the senior sister. They are now exiting to move to a cubicle where they will deliver definitive intensive care. We can see that there's an ID nurse assisting them with this and also following them to decontaminate behind them. So the team have now arrived in the cubicle, which is where they will be delivering definitive care and ongoing intensive care.